Hello, this is David Wallace, and I'm reporting from the American Society of Hematology Conference here in Atlanta, 2017, after a nice snowy few days. And we are here today, joined with us Dr. Raajit Rampal, and you're with Memorial Sloan Kettering Cancer Center in New York, New York.
Correct.
Great, and I appreciate you joining us again this year at ASH.
Pleasure to be here.
Absolutely. Wanted to talk to you, first of all, about one of your studies, and this one involves the advanced forms of the myeloproliferative neoplasms are associated with chromosomal abnormalities involving 1q and 12q, implicating MDM2 and MDM4 in disease progression. If you could talk to us a little bit more about your findings on that, I'd appreciate it.
Sure. So this was a study that was done principally at Mount Sinai with some contributions from us at Sloan Kettering. And the basic story really revolves around a gene that's called P53. And P53 is the master regulator of the cell. When cells have damage, DNA damage, it is part of the mechanism that tells cells that they should die instead of accumulating more damage. Now, about 3 to 4 years ago, we published a story looking at when patients who have MPN transform to AML, how does that happen? Part of what happens is that this gene, this P53 gene, becomes mutated and doesn't function anymore. And so the JAK2 mutation can cause some DNA damage, which accumulates over time in the cells, transform to leukemia. Now, this story very much is another sort of tangent off of that story. These proteins that they're talking about in the abstract, there is MDM2 and MDM4. What these proteins actually do in the cell is that they actually bind to P53 in the cell. And when they bind to the P53 in the cell, the P53 can't do its job. Now, if you have too much MDM2 or MDM4, then it's going to bind the P53 in the cell, and it's like having a mutation in it. It means it's not going to function. So, what this paper looked at is abnormalities in chromosomes 1 and 12. Those genes, MDM2 and MDM4, are on those chromosomes. What the principal finding from the study was that in certain patients who have progression of their disease, there are extra copies or segments of those chromosomes, which means you have extra copies of those genes. And if you have extra copies of those genes that have MDM2 or MDM4, you're going to make more of the protein, which means that it's going to bind up the P53, which means we'll have less P53, and that means there can be more DNA damage.
Okay, and let me ask you along those lines, would this require one of the advanced gene studies to find out whether or not a patient had that particular gene?
It's a really good question. This one wouldn't so much involve getting what we call molecular genetic testing, that's testing for mutations. What this type of testing would require, what this information would require in terms of testing, is for a patient to undergo what's called a karyotype or a FISH analysis. And what those tests are is that they look at the changes in the chromosome. So when we talk about molecular genetics, we're talking about mutations in individual genes, and when we're talking about karyotypes or this analysis called FISH, we are looking at big pieces of chromosomes which contain lots of genes on them.
Okay, all right, thank you for differentiating that for our readers. You know, we talk about progression, and I have to say myself as a patient as well as our readers are always concerned. Two-part question. We tend to hear average findings as far as progression to MF and AML, maybe 10 to 15%. Does that sound in line, or what are your findings?
You know, I think one of the things we're beginning to appreciate is that we often apply these statistics to populations, and so we come up with average times to progression. But statistics apply to a population. The question becomes, can we get better at predicting for an individual patient who we see in the clinic, what is the risk of that patient progressing? Because it's certainly not the same for, patient A, B, and C who we see in the clinic.
Sure.
And I think that's where a lot of the effort is lately in terms of applying what we've learned in regard to risk. And we can use mutations, we can use clinical factors. And so a number of groups have been working to develop new score systems. There was one presented at ASH this year called the MIPS. It's a revision of a MIPS scoring system that was presented several years ago. And that scoring system tries to take into account patient factors, but also mutations to see, can we actually make a model and put a patient's information into this computer program and say, somebody has X% chance of progressing at 5 years. That is what we're trying to do. Again, no model system is perfect.
Okay.
And so when we talk about this type of information with patients, we have to be very careful, because at the end of the day, none of us can predict the future.
Mm-hmm.
All we can do is make our best guess based on the evidence that we have.
Okay. I know that in the conclusion, you mentioned that these data suggest that MPN disease progression is associated with the specific chromosomal abnormalities that result in upregulation of the MDM2 or MDM4, which further downregulate the P53. And I think it goes on to say these data provide the rationale for the use of MDM2 and MDM4 antagonist as a means of halting the disease progression. So that begs the question for me, are there drugs in development that will act as these antagonists?
It's a great question. As much as we want to first figure out what's going on, we want to be able to try to act on that. And as it turns out, there are MDM2 inhibitors that are in clinical trials. There are drugs called nutlins, and their job is to actually interrupt the association of the MDM2 or MDM4 proteins with P53. And if you do that, that frees up the P53 protein to do its job. Now, interestingly, there was data presented on one of these drugs called idasanutlin from the Mount Sinai group at this ASH, and it was for patients with PVNET that was refractory to either hydrea or to interferon. And there was actually activity seen in greater than 70% of patients, and in fact, patients' symptoms improved. Now, can we potentially extend those findings into a trial for patients with myelofibrosis who maybe have that 1q or the 12 abnormality? I think that's the next logical step, but I think the important take-home point here is that there are actually drugs that can target this abnormality, or the results of this abnormality.
Okay, all right, very good. That's exciting and something we'll look forward to in hopefully the near future.
Absolutely.